Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and to delve into the challenges and impact each technology has in practice. This is the Medtronic MedEd learning experience. The BIS monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Reliance on BIS system alone for intraoperative anesthetic management is not recommended. Medtronic's medical education programs are offered to provide attendees education on the FDA-cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidien LP, a Medtronic company, for this speaking engagement. For this segment of the series, a discussion on anesthesia in the brain, we will answer the question, what issues could impact the BIS monitoring values? To help answer this question is Dr. Stephen Bader, Chief of Cardiothoracic Anesthesiology at Heritage Valley Health System in Beaver, PA.
So common issues that I think everybody who uses the BIS should be aware of are, anesthetic agents that we are commonly using for balanced anesthesia, maintenance agents such as anesthetic gases or propofol infusion. I think people are very comfortable with, but then they see unanticipated results when they give boluses of less commonly used, at least used to be less commonly used anesthetic agents. A great example of this is ketamine. So ketamine has come and gone in clinical popularity over the years, but it certainly is in the limelight right now. I would say that I've seen more ketamine use in this last year than I did in the previous 15 years of my practice. And I think that that's only going to continue. There's a lot of interest in the literature in ketamine adjunct for pain management and overall ERAS protocol, earlier emergence and lower dosing of other things. But one thing you have to be aware of with the BIS monitor is that ketamine may transiently increase the BIS number, even though it's deepening your anesthetic, because it acts very differently on the brain than most of our other anesthetic agents. And I think people are frequently giving ketamine as a small bolus in response to surgical stimulus and perceived light anesthesia, and then they see the BIS number actually go up in response to their drug. So it's very off-putting. I don't want this number to go up right now. I want the number to go down. That's why I'm giving a little bit more ketamine during this stimulating period. So you just have to be aware of that particular pitfall. Etomidate can do it too, although it's really much briefer. Essentially you get myoclonic jerking with etomidate boluses in some patients, and you would see, if you had the monitor on during induction, you'd give etomidate and you might see, a few myoclonic jerks and then some transient increases in the BIS, even though you have the patient at induction level of general anesthesia. We don't use halothane much anymore, but it certainly has higher BIS values than the other anesthetic gases. And nitrous, again, come and gone in popularity. Used to be that almost every general anesthetic of an inhalational agent had some nitrous on board, but thanks to the Enigma trial and subsequent loss of interest in routine use of nitrous, you don't use it as often. But in the real world of clinical practice, it's still out there. People are still using it, and you have to be aware that nitrous oxide may not have much effect on the BIS number itself, while it does still have an effect on the patient's depth of anesthesia. And one interesting side effect of ephedrine, we routinely use phenylephrine and ephedrine to raise the blood pressure during general anesthesia. And ephedrine is, a central nervous system stimulant, in addition to having its cardiovascular effects. There's people who drink ephedra teas that contain essentially ephedrine as stimulants throughout the world. So it is not too surprising that it may increase BIS values while not actually having a huge effect on their anesthetic state. So another common pitfall to interpretation that is one of my favorites is, EMG, the component of the BIS, analysis that results in the number, has EMG activity of the forehead muscles as a big part of the algorithm. And that makes sense if you think about it. If somebody's grimacing, raising their eyebrows essentially during the anesthetic, that would indicate light anesthesia. So if there's a ton of muscle activity underneath the sensor, you're going to see higher BIS numbers. So what I frequently hear people say is, as an example, during a general anesthetic, well, I induce the patient with propofol and rocuronium and fentanyl, and half an hour, 45 minutes into the procedure, I'm noticing that my BIS numbers, after being relatively stable for the first 20, 30 minutes of my maintenance phase, are now starting to rise. And at the same time, I happen to decide to give more rocuronium because I needed surgical relaxation, and the BIS number dropped precipitously. So that really upsets people. If you're relying on this device to monitor the brain state, and then you give a neuromuscular agent that causes your brain state monitor to tell you that the patient's deeper, it's something that I think really puts people off with the monitor. But it's actually totally an appropriate response when you understand that the algorithm increases the BIS number in response to EMG artifact, and as muscle relaxant wears off, you're going to see the BIS number rise and subsequently see it drop if you rebolus neuromuscular agents. So, just being aware of that can give you much more confidence in the device, even though that doesn't necessarily make you feel good when you're first getting to know the device. Some other things that you should think about, medical devices in the room that cause electrical activity, can affect obviously EEG artifact, and therefore the number that the BIS generates may not be as reliable. So if they're suddenly starting to bovie a lot up around the head or in the upper chest, you may see that reflected just because there's so much electrical interference in the patient from those devices. Anything with a motor on it, forced air blowing devices such as the warming devices we use, or some of the suction devices that are in there, shavers, mechanical drills, any of those things can cause electrical interference. It's going to result in spurious BIS numbers. So if you're paying attention to what's going on in the room, you'll anticipate that, oh, my BIS is giving me crazy numbers right now, but I think they just started using that loud, buzzing device. It makes sense that, it would interfere with the BIS. So you can take that into account. Other things that are going to result in BIS numbers that don't necessarily correlate, if you have unusual neurologic activity because of pathology, right? So somebody has a previous brain injury and they have very abnormal baseline EEG activity because they had a big stroke or a traumatic injury to their head, that they may not have appropriate responses. If there's and so you just have to be aware of that from the baseline. If there's an intraoperative event resulting in, brain anoxia, right? So you have inadequate blood flow or inadequate oxygenation to the brain, and you see really strange or very, very low BIS numbers, that can actually be sort of diagnostic of a problem. It can tip you off that there's something wrong. If you have somebody who's got a severely kinked carotid artery because of the way they're positioned, you may see, very low BIS numbers that don't correlate to the anesthetic. Certainly when we have a patient who has cardiac arrest or very low cardiac output, we see this in the heart room. Unfortunately, when you have sort of failure to wean from bypass very effectively, and now you have 15 minutes of profound hypotension and low cardiac output state immediately post pump before you crash back onto pump, you're going to see really low numbers on the BIS that have nothing to do with the anesthetic agent. It's strictly about the patient having, very low blood flow to the brain at that time. So think always of other pathologies to the brain that could be causing your problem. And don't forget about being very cold, having a profoundly low blood sugar, any of those things that can decrease cerebral metabolic activity independent of your anesthetic agents, should be on your mind as possible reasons you have this change in the BIS that really has nothing to do with your anesthetic agent.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.